Dear colleagues, dear guests, good day. I'm Dr. Georgi Valchev from the University Hospital of St. Marina, Varna. Let us begin with the presentation. So, the whole purpose of radiology is to report findings. However, the radiological report needs to contain crucial information and also as much additional information as possible to make the clinician's life easier. However, that is not necessarily always possible due to time constraints and the increasingly climbing radiological workload. So a compromise in all situations must be achieved, in which cases sometimes we must sacrifice details for expediency. The biggest findings do get reported, but smaller ones might get overlooked. First, we'll present a review of relevant literature, starting with a small summary of the basic approach to reporting MRI of the lumbar spine presented at the European Congress of Radiology in 2018. I will not go over all of these points in detail because they are very mundane and well known. The references are shown below. Interpretable disk spaces, adjacent soft tissues, etc. Everything is quite well understood and also available online at the pointed out references. Next up, we have chosen a select list of entities with high clinical relevance, which due to their very high frequency are of great interest to radiologists and also to software developers who aim to help radiologists in their search for optimizing their workflow and delivering more information faster and of higher quality. These are the 5 entities: disc herniation, spinal stenosis, degenerative disc disease, spondylolisthesis, and additional useful information, for example, nerve root variant anatomy. Firstly, in the case of disc herniation, Lurie et al. Reports that among patients with intervertebral disc herniation, those with thecal sac compression exceeding at least 1/3 of the sagittal diameter have greater surgical treatment effect than those with small disc herniations or those with moderate type changes. This publication also compares patients who have not undergone surgical treatment with those who have undergone surgical treatment. You can see more details down below. In the case of spinal stenosis, routine preoperative lumbar spine MR can predict the patient outcome in 2-year follow-up in patients with lumbar spine stenosis surgery. Additionally, in the case of spondylolisthesis, Pearson et al. Report that among the patients who are treated non-operatively, those with the lowest grade spondylolisthesis showed the greatest amount of improvement, while those of higher grades and those with hypermobile spondylolisthesis are with less satisfactory therapeutic results. Finally, here we have a small schematic of all the potential variant anatomies of lumbar spine nerve roots, which needs to be very carefully examined preoperatively in order to make the life of your neurosurgeon easier and avoid iatrogenic catastrophes from potential oversights. I will now present you a short review of the results of the survey that you have all filled out so far, in order to see the most important aspects that we will stipulate, and then hopefully we'll get to discuss all of the minutiae and all the small parts of it when we get together in Vienna, hopefully in July, during the roundtable. We have separated all of the findings in several different categories, one of which is the category of consensus. The findings listed on this particular slide are points of 100% consensus among all respondents of the survey. They say that they will always report all of the following entities, which is of course understandable. They are all of substantial clinical significance and they should not ever be omitted. Next up, we present a small list of topics with a prevailing opinion, meaning that a large percentage of respondents, usually over 80, voted in favor of one particular side, but still no 100% consensus. These include the reporting of osteophytes, facet joint changes, nerve root anomalies when they are not symptomatic, herniations in protrusion, extrusion, subligamentous or extraligamentous types of herniations, also lumbosacral transitional vertebrae and high-intensity zones and annular tears. Additionally, lipomatosis and finally modic changes are mostly favored to be reported by the greater percentage of respondents. We must take into account another topic that is not currently among the respondents with a full consensus. The majority of reporting radiologists say that they would always have the patient's clinical picture into consideration when looking for pathology on the imaging, thereby possibly discovering any pertinent pathology very quickly, but also potentially omitting any smaller findings which are not relevant to the current clinical picture. It is important to note that a minority of our respondents did not say that they are taking this clinical information into consideration, and they are describing everything very carefully and assiduously without looking at the clinical picture first. Those two respondents are two of our respondents from the United States. Next up, we have a few select topics of which have still lack of consensus, but there is no overwhelmingly prevailing opinion. These include the mention of pseudolisthesis in a report without symptoms, Schmorl nodes, spinal canal with reporting, etc., etc., disc hydration reporting, and so on. The presence of Schmorl nodes is favored to be reported by majority, but not an overwhelming majority of respondents, and they could potentially be significant in the long run, while not always clinically relevant at the time of imaging. The spinal canal width is a very sensitive topic because usually when it is not, when there is no compression and when it is not narrowed, the radiologist doesn't have time to report it, even though we would like to report it more often. That, however, could be made easier with automation, but given our current workload, it is in most cases not really feasible. There are several reasons for performing extra sequences in clinical MRI of the lumbar spine, with them being listed in our survey, with one being the most frequent and four being the least frequent. We can appreciate that the sequences added by the radiologist for specific pathology at specific levels are the most overwhelming example. Patient motion artifacts are the ones that present the second most important category, and other categories are less significant. All of these specific minutiae of the reporting can be affected by time constraints and potentially alleviated by the presence of time-saving automation. Thank you all for your attendance, and thank you to all the speakers for their contributions.